evening and welcome everyone to our Black Beetle Health panel discussion. Thank you all for taking time out of your evenings to come and talk with us, interact with us. We're glad you're here. So my name is Sarah Grant. I am one of the Health Education and Resource Development Officers of Black Beetle Health. I'm in the chronic illness and disease area of Black Beetle Health. That is my role. And I'm going to give the opportunity for my fellow panelists to introduce themselves and to just briefly give us their role in Black Beetle Health. Adelaide, you can go ahead.
Hi, I'm Adelaide. I'm one of the Health Education Resource Development Officers in sort of women's health and inclusion. I'm a registered midwife. That's my kind of other role that I do. And yeah, I'm really looking forward to this discussion this evening.
All right, Harvey. Thank you.
Yeah, good evening, everyone. So my name is Harvey Kennedy Pitt, and I am representing sort of sexual health in this space this evening. So I'll be sort of lending my expertise or my knowledge or my experience in that area. So thank you for having me.
Thank you. And Philippa, you're muted.
Sorry about that. Hi, I'm Philippa Peard. I am the Mental Health Resource Officer at Black Beauty Health. I am a doctorate student at the University of Wolverhampton. My research is around mental health promotion in Black and Asian communities in the UK.
All right, awesome. Thank you all for joining today. Now, we all are members of Black Beetle Health, and today we are going to be discussing a really dynamic topic surrounding health at every size. It's something that we've been promoting the past couple of weeks, and we've had some great feedback already from our community members. So we look forward to going into a little bit more detail. We have an hour, because of course we're always mindful of the time of our panelists as well as our audience, but we wanna just go ahead and set the stage for it, and then we'll go in and allow you all to ask any questions. Now, while we're talking, you can always put your comments or questions in the chat, and we'll be sure to include those in our discussion. So just to make sure that everyone is aware, Black Beetle Health is a public health community organization dedicated to promoting health, well-being, and equality for LGBTQ+ communities of color by shedding light on important health disparities among these communities in the UK and around the world. So our mission is to promote health through evidence-based, peer-reviewed research, resource development and signposting to culturally sensitive, safe services and support groups for people of color throughout the UK. So I want to make sure that everyone knows our mission. That basically means we are here for our community to present information that is accurate as well as empathetic, as well as culturally appropriate. And I hope that you all get that sense today as we talk. So I'm going to be representing more of the chronic disease branch of Black Beetle Health. We also have a sexual health representative here. We also have a diversity and inclusion representative here, as well as our mental health. So we like to look at health as a whole, health and well-being as a whole, and not just choose any one part of representing what health is. So of course, as we continually put out information and content to our community, making sure that you have the resources and information you need, we try to touch on different departments. And so looking at the area of chronic illness and disease, one topic that comes up is the area of weight. So it came to me as a person who has studied public health for has completed a public health degree, a master's in public health several years ago, and who's also a certified health education specialist, that this is one aspect of health that comes up a lot in our training. And as a diabetes educator, amongst various other roles, my job is often to translate that topic and how weight relates to a person's individual's health and put that into realistic terms. So when we talk about weight, People, the medical profession across the UK and globally tends to associate that as a simple method of classifying a person's physical health status. Of course, they may use terms such as BMI, which the average person may or not be familiar with. They may use terms you may have heard about in the news and elsewhere, talking about the increased risk of complications for people who are at increased weight as it relates to their risk of certain chronic conditions such as diabetes, hypertension, and others. So these are things that in my training I've heard about, this term used often as a way to quickly classify people. But we also, when we quickly want to classify, we also run the risk of oversimplifying issues, excluding certain people, and not really capturing all of the social and environmental factors that play into what it means to be healthy. So in talking to some of my colleagues, this is how we ended up coming to this discussion, topic. You know, we talked about how do we capture the historical impact of weight? How do we capture the differences in amongst different ethnic groups as it relates to weight? How do we capture the pressures that come from society and culture as it relates to weight? And is it really an adequate depiction of what it means to be healthy and how a person feels about themselves? So we want to spend some time talking about that today. Of course, because I do represent the chronic disease component, I'm just going to drop a few stats just for context, and then we're going to open it up to the rest of my panel here. So again, the term BMI is one that is used often to describe a person's weight. BMI is used, it's a calculation that incorporates a person's body weight and their height, okay? Now, of course, this may not consider a person's ethnic group, whether they are more muscular, whether they are at a greater weight because they're an athlete, whether that they're at a greater weight because they have underlying conditions, whether they're at a greater weight because that is culturally acceptable in their nationality or in their place of origin. So there's different reasons why BMI might not be the best indicator to the average person, the ordinary community member, about why it's important to achieve a particular ideal. And then of course, people may ask the question, well, who sets this ideal and why is it important to me? So as a health educator, I have the privilege of bridging that gap for my patients and clients and saying, well, what is your why? People may not say because I want to achieve this particular BMI, but my why could be because of how I want to feel about myself, because of things that I want to achieve. There's different reasons why, and it's my role to make that clear. It's also my role to be an advocate and say, well, doctors who may give these recommendations, is the person able to access healthy foods within a 5-minute drive of their house? Is their neighborhood safe for exercise? When we throw out certain terms, you know, the guidelines always say to lose weight, exercise and diet, exercise and diet. But what does that really mean? And is that really realistic? Do people, when they have technologies that come out to manage certain conditions, can they afford these apps and these technologies? Are there physical limitations or other conditions that make it hard for a person to achieve that? So there's a lot of different things. And Jack, thank you. You're already hitting on something that we talked about in our panel. The idea that the BMI scale was actually devised by a non-medical man, and it was created to measure the health of communities, not individuals. Yeah, it seems like we were having that same discussion as well. So this is a perfect segue for me to turn this over to some of our other panelists, and I just want to hear from you. I'm going to go ahead and start with Adelaide, if you don't mind, since this is a perfect segue. Tell us, in your perspective, how you apply the topic of weight within the area of diversity and inclusion, and if you want to also touch on the area of maternal health and your expertise as well. Just tell us a little bit about how that applies in your context and why it's important to not just hone in on one measure.
Yeah, absolutely. So I guess the first thing to say is that the term health at every size, which we've used, is actually a registered term. It is an approach that was created by the Association of Size and Diversity in Health. And the idea, it is a kind of an evolving approach, fairly sort of young, which is to sort of, it's an alternative to like weight-centered approach for treating clients or patients in all situations. And it's a movement that's working towards the promotion of size acceptance to end weight discrimination, body weight stigma, and help sort of lessen this kind of cultural obsession with weight loss that sort of pervades within our society. I think for me, as a healthcare professional, I've had a very kind of recent awakening in this idea of perpetuating body weight stigma in the name of health and in the name of medicine. And that's really sort of caused me to look at the way that I support people, the way that sometimes, as you'd said, Sarah, that weight can be used as a proxy, the way that some of us in black and brown skin will find that, you know, race is used as a proxy for us to kind of make shortcuts about our health and the interventions that we need. So I think it's really important for us all to just be mindful of how we approach that, and actually to think about healthism, which is one of the I guess it's a key bias that people may not even realise that they hold. And healthism is the idea that following a particular set of health behaviours is considered to be good, and if you don't do that, it's bad. You know, therein body size or body weight can become like a moral issue. And I think one of the really kind of key factors within this is this idea of like individualism. And again, you touched on this as well, Sarah, which is that the implications of the focus on an individual in relation to health status doesn't give consideration to social and economical and physical barriers that might contribute to the development of like a lifestyle related disease. So that's just a kind of quick overview of sort of some broader terms. And then the other thing, I guess, in relation to what I see within maternity care, I personally feel like I see quite a lot of gatekeeping, that because time is quite short, and in the UK we have a National Health Service which is free at point of access, which is incredible, but it does sometimes mean that we are using this shortcut to try and assess you know, a risk category or something like that. And so even though when you look closely at the guidance, it is the RCOG guidance is worded that most people will have healthy pregnancies, you know, if they're of a higher body weight or in a higher weight category. However, the way that is then implemented, it can become a sort of a very regimented process. So we're just ticking boxes and we're putting people on scales, and we're quite shamefully, I would say, and this is just my personal opinion, I must express this, we're then partnering with, you know, diet clubs and slimming programs and things like that, and promoting that to women and pregnant people. And I do take issue with that. In relation to the kind of wider implication of gatekeeping, which is to say that because your body is this size, or because you tick this box in terms of you know, a BMI, which is always the measurement that we're using, it is not advised that you are able to use the pool, for example. Yet we know that there are benefits to being able to labour in water. Or we would advise that you are cannulated just in case, because actually if a health professional needs to cannulate you in emergency, it might be difficult for them. So all these kind of things, interventions, and even things like continuous monitoring, which may occur, although has uses in itself, it, it is it can be responsible for increased intervention in terms of like cesarean sections and things like that, because we're over monitoring and maybe over diagnosing fetal distress. So that's a real kind of whistle stop tour, but hopefully that gives you just a bit of an idea of where I come from as a practitioner and the kind of things that I see.
Thank you so much. That was some great feedback. And I'm going to pass it over. I'm going across my screen here. I'm going to pass it over to Harvey. Harvey's going to give us more of the sexual health context. And then Philippa, the mental health aspect touches all of us. This is very relevant and we're looking forward to hearing what you have to say. So I'm going to pass it along in that order.
Yeah, I just want to just jump right in there and say, when I was preparing for this to sort of pull together my resources and really reflect on my own practice, the findings are so varied. It's so wide. It ranges all the way from sort of very traditional approaches that Adelaide sort of spoke about, weight loss, things like Slimming World. Oops. Names and branding there, slimming programs and things that focus on like getting down to an ideal weight, and frankly it ranges all the way across to things such as fat phobia, which I think we need to really start addressing in our terminology this evening. Fat phobia, things like desirability politics, how desirable is a person when they're seen to present a certain way, where those ideals come from, the way that people access sort of dating apps as well. That's something I'm just speaking from personal experience. People do tend to be extremely negative and judgmental on dating apps because of that sort of ingrained ideal of what an attractive person looks like. And so I have got some academic literature that came up, and I did have a little read, and there are certain references that come up in that literature that speaks about its link to what we call metabolic syndrome. So you might know them as sort of like high blood pressure, or you might see them as like diabetes, or things that are affected by that can be affected by weight, they say in that literature, and they have some stats about how it affects sort of males and females, which again, it's important to notice, so I noticed that you've again excluded sort of non-binary people, you haven't got any data on trans people, so where is that going? In chatting to Adelaide sort of earlier on in the week, or maybe last week, we spoke about things such as who is funding the research that is coming out that we're accessing as academics, and how's that influencing our practice? And that's really where public health sort of comes into play, where it should come and sort of join hands with sort of clinical practice. So, Adelaide is a clinician. She deals is sort of like what we say is patient facing. Doctors, nurses, they might be bedside. They might be dealing directly with things like cannulation, so that's going to be explained, I'm sure, at a different point, which is trying to find veins, trying to get trying to draw blood, or trying to administer some type of drug. So they'll say, we can't find your veins because due to whatever criteria they've decided, it's difficult to find your veins. And there might be some truth to that, but at the end of the day, thinking about how we approach that on an individual basis when it comes to how people engage with the dating scene, when it comes to their perception of self, their confidence, the ability to I think I made a note here of wanting to, when they look in the mirror, how desirable do they feel? What is their perspective on how they think they present? And where does that come from as it relates to traditional views around body image? So they even state here that things like sexual dysfunction, there is no actual definition for that. People are saying, I think that sexual dysfunction is this, or I think sexual dysfunction is that. But there's no universal approach to, okay, what is that exactly? And the reason is because of those varying views. There's no way to determine classify that in a way that would be acceptable across all specialties, across all sort of research, because of those biases, like who's funding it, like who it's in the name of, who it's meant to benefit, and who it's meant to hurt. If I'm quite honest, who are they trying to hurt? We speak about race, we speak about the way that people have been racialized, and how they often link racism to they utilize these BMI categories and things to link to racism, to worsen the effects and outcomes for certain groups. That's not discussed very openly in literature as well. I was recently looking at some resources by someone named Sonali Rashatoire, I think is how you pronounce her last name. But oh my goodness, you know, how eye-opening is it to talk about things like body autonomy? You know, how much do I feel in control of how I'm feeling and how I want to make decisions around my health? You know, in a way that that leads to confidence, that leads to self-acceptance, that leads to how I sort of enter the dating scene, how I engage sexually, and the cycle that you enter in between mental health, sexual health, social health, emotional health, and back around again. And how sometimes when we sort out mental health aspects, you start to see yourself flourishing in sexual health aspects, and other actions might change. So that's sort of what I'm sort of finding initially. It just to lay the foundation for sort of where I stand on that.
Thank you. Very thorough summary for us. And we're going to come back to some of the things that you mentioned as well. Philippa, please share with us how weight factors into mental health. And again, as Harvey just said, it's a cycle. Weight factors into mental health, but mental health also affects weight. Tell us more about that and what you found in your research. Make sure to unmute yourself. Thank you.
Sorry about that. I would like to start with positivity comes with that everyone, regardless their background, deserve to have a positive image. No matter how a society and popular culture view ideal shape, size, and appearance. And we have an issue with the lack of acceptance of body shapes, especially as a Black woman, speaking about other Black women, where we are going to the society that we have to be, or we have to have like our hips or thighs have to be really a certain shape, our bottom has to have like a really curvaceous shape, and we need to have like what they say, a Coca-Cola body shape for us to be accepted in the Black tradition and cultures, which is very high at the moment. I don't know if you've seen the Busset challenge that's been going around on social media where women, like particularly Black women, are dressing themselves in like oldie raggedy clothes, and then they go down, do that little stoop down, and then they come up and they're dancing and they're showing their hips, their thighs. They feel like they need to do that to be accepted. And I see that a lot around social media. And I think it has a lot to do with, I'm not saying I'm blaming anybody, but the way Black men perceive their women and show how they want the women to be, it does seem to have effect on a lot of Black women and how they should behave and how they should look. As you see, you have Black women going to Turkey to do cheap body enhancements, and they end up dying or damaging themselves, or end up being disabled, but due to of what the attention they need Black men to give them, because Black men seems to give out the perception, if you don't have a big booty, if you don't look curvy, if you don't have big thighs, that's what I want my woman to be like, or else I'm not going to give her anything, I'm not going to show her any commitment. And it affects us Black women. I have to say, did it affect me? Not really. But I do think that this causes low mood and obviously depression, to the point where they're going to other places to do cheap body enhancements. So this causes a bit of anxiety. You have some women, I've known some Black women that don't like to wear tight clothes because they don't want to show the true shape of their body. They don't want to show, what they were born with. They're not going to show that till they've done some serious diet plans, or they've been to the gym six, seven times a week. No time for themselves. They come from work, they're going to the gym, go to gym in the morning, and that's how depressed and dissatisfaction they are with their bodies, to actually go to this excess activities to get the body weight and the body shape of what Black men want them to be perceived as. Because as much as they like to deny it, Black men has a lot to do with it, because from our roots and background, Black men, they love curvaceous women, right? And it's been passed down from generation to generation. And I think in my generation, it's really how their bodies don't want them to be. causing that delusion on women. No, if my body's not like this, I'm not going here. I'm not going to wear this certain type of clothes. And that's how it is at the moment with mental health issues, depression, and anxiety of how they want their body to be. And I think more cultures of where a lot of women are at the moment so far, but that's all as far as I can say right now. But in and then you have social media, which does help. You have Instagram, who shows what they think women should like. They continue to advertise courageous women to the point you can't even see their hips. Like, it's thin, you can't see anything. You just see booty eyes, and it's a continuous cycle that keeps going on social media, especially Instagram. What a woman should be, what a real woman should be like. She should be like a Coca-Cola shape. And if you're not that, you're not a real woman. So this affects us women, Black women, and how we're become really delusional how our body should be like, which is causing death and disability in our ethnicity. Can you hear me?
Yes, the connection was a little blurry, a little broken at times. But I just want to touch on what you just said. Thank you very much, Philip. And I want to expand that out because, of course, the as you just mentioned, within one ethnic group, there could be one perception of what is considered beautiful, and it came from in many of our groups of color, people of color, especially, these came from a rebound response to the quote unquote status quo, which was the quote Western, or should we call it maybe European or white, whatever term you want to call it, the white perception of what is considered ideal weight. So, there's that, again, that body positivity, accepting that people of certain ethnic groups might have more curves than others or things like that. So it came from a good place. But again, having that balance, if we take it to another extreme, it can actually have some effects on mental health. Can you talk about the perspective of people of color or people within the LGBTQ community as far as accessing healthcare and the issues regarding acceptance? Somebody in the comment section actually just mentioned, let me go back really quickly. Somebody just mentioned that they have multiple issues that they're dealing with, and they're concerned about accessing mental health services because they feel like they may not have a clue about how to deal with all the different facets that make them a person. So can you talk about that in the larger context?
Mental health services, sometimes it depends culturally on who you cross, really. The IEP services are a lot available, but it's just depending on issues in the institution themselves. I think accessing mental health services, I think it's just knowing who to contact and which services will be better to suit your needs.
Mm-hmm.
As in,
well, I guess what I mean,
you have agents. Carry on.
Sorry, I'm kind of thinking about the reluctance that some groups might have because they may not be perceived favorably if they are seeking out these health professionals for care. Have you heard in your experience, and I'll also toss this to Adelaide, have you heard in your experience about issues that come from that reluctance to pursue health services because of some of these, and how it can affect people from a mental health perspective and also physically?
I mean, yeah, I could probably speak to that a little bit. So I think if you look just generally, the really key thing here is we always talk about intersectionality, don't we? This a term coined by Kimberly Crenshaw, and it's just this lens that you use to look at the way that people's sort of different identities that they hold intersect. And I think if we're thinking particularly about sort of people, Black and brown people, the kind of care that they might receive when they approach healthcare professionals. which is can vary. Some of that might be to do with the teaching that that healthcare professional has had. So diagnostics, say on a certain type of skin colour, is just one example. In the area that I work in, so kind of maternity, there's sort of a disparity between the deaths of Black women and women of other minorities, other ethnicities, sorry, or minoritized ethnicities. And it's really important as well that when we talk about that, you know, they only record them as women, so we don't know if they actually hold another gender identity. What we also know is that with people in bigger bodies often put off going to seek healthcare because they walk in the room, and I've heard sort of trans people talk about this experience as well, which is that everything is like, oh well, have you tried losing weight? Like, my finger's just fallen off. Have you tried losing weight? First thing, not even, you know, no questions. That's like the first thing. Or
and somebody just mentioned that in the comments as well.
Yeah, a trans person walks
was
into
about losing weight. Yeah.
their doctor and says, "Oh, I've got this like weird sort of like rash in my eyebrow," and they're like, "Oh, we'll refer you to the gender, clinic." Like, okay, that's cool, but I think like this rash in my eyebrow, I don't think has anything to do with the way that I view, you know. So if you think about all these kind of things on top, when we think about marginalized identities, often they, because of the way that the power paradigm presents when you're seeking health support, as in you're at the bottom going to somebody, you have to go with your cap in your hand to say, I need help with something, you've really got to put your trust in that person. And if people that you know have had poor experiences, or you think you're just going to get a lecture about, oh, have you done this, then why would you go to that place and ask for help? It doesn't make any sense, does it? You know, when you've got a friend that's going to say, I told you so, you're like, you put off going to that person for advice, wouldn't you? You know, and I think as health professionals, we have to be really mindful of that. We need to be not only welcoming, but we need to view people as individuals, because as institutions, we're not necessarily that welcoming to people that feel marginalized. And again, someone mentioned in the chat there, neurodiversity. Again, if you know ADD or if you have autism or any of those kind of things, people like will just hone in on, and that's the thing, you know, before we can kind of get anywhere else. So I guess in answer to your question, or if there's anybody sort of looking for support services, what I would say is where you can sort of have a good sense of what it is that you want from the healthcare professional that you're approaching, and remember that they work for you. It's quite an unpopular sort of thing, I say it all the time, but you are the individual and you need to access care, and it is their obligation to help you. First, do no harm. That is, you know, medicine. So you can do that part, and then if you're here as a health professional, then you can do your part by thinking, well, how do I hold the power in this situation, and let me just treat every person as a blank slate, and I'm trying to get to know them as an individual, rather than looking at their numbers, looking at the color of the skin and doing those kind of things and making a snap judgment. And it is easier said than done because of time, but it is so worthwhile to take that time to get to know a person as an individual, because we as yet cannot say all people in bigger bodies will suffer XYZ, or all people in smaller bodies will never have XYZ, because that's not possible. We're all individual people made up in different ways. So
I think it's also important to, I just want to jump in there and say that it's important to say that it's not assumed that because you find a practitioner of colour, or maybe even someone who identifies themselves as LGBTQ plus, LGBTQIA plus, that fits a certain description that you're needing, that you will get on. Okay, there are many people who go into services looking for someone who looks like them, and they receive the biggest disappointment of their entire medical experience, because that person has not taken time to go and do the footwork and to do the background research to ensure that they are also providing inclusive practice. So we can't assume. I know that the the NHS long-term plan from 2019, from the convention was announced that when we increase rates of practitioners of colour in certain spaces, then there's automatically positive health outcomes that are going to be seen as a result of that. Okay, to a certain degree, but there is still that structural, the structural politics and the structural constructs that are there that affect, how true that is. And so, you might very well go seek a certain service, whether it be sexual health, mental health, chronic illness and disease, or anything else, and find that actually you found a practitioner who does not identify as LGBTQIA, they do not identify as POC, and they are working a dream for you. So keep an open mind. Don't sort of think that, oh, I've got to go and find a practitioner of colour, but really that you need to think about what's best. Who is helping you to achieve the goal you come into trying to achieve? And so really thinking about that first and foremost, and not maybe falling into a model that someone's maybe fed you, because you might find that the benefit is right there, if they happen to tick the box, which is most important, which is, are you fulfilling my needs as your client?
Mm-hmm. Thank you. That was a good point. And I was actually going to toss it back to Harvey as well. So in the comments, somebody just agreed with what you were saying, that someone, Beth, says that their recent psychological assessment was worse because verbally the psychologist got them, but in writing they misconstrued what they said regarding structural oppression on their mental health. So I also want to add that what I've heard from the panel today is that doctors and physicians are trained. They've gone to school. They know their area. However, or in addition, there are other supportive health professionals and services that paint a broader picture for us. And I'm going to give the opportunity, if you all, thank you so much for the feedback we've been getting in the chat so far. It's been some really good testimonials, and I appreciate you all sharing your personal stories and giving us perspective along with what we've been saying. If you have any questions, we're going to allow this time to really go into the chat and answer your questions to the best of our ability, or if we can't, we'll give you some resources where you can seek out more information later. So please go ahead and do so now if you have any questions about what we've talked about. But I do want to just mention the benefit of seeking out what we call auxiliary services or additional services, because doctors are trained on the clinical piece. Times are changing where they're learning more about the nutrition piece or the sociology piece. Sociology meaning, what are the social effects on a person's physical health, things like that. They're learning about those different areas, the mental health aspect. So it's about, number one, advocating for yourself and saying, okay, if the physician doesn't know how to address my particular things, then can they refer me to someone who, there are coaches like myself, educators like myself who can address some of those things, educators like Harvey, who can address more of the sexual health piece. So definitely tapping into those different things. And Harvey has dropped the name of the reference that he commented on earlier. So while we're waiting for some questions to come in the chat, I do want to ask Philippa, what would you say is the link between healthy lifestyle and mental health outcomes, or is there a link? And of course, we talked about that, how it's a cyclical thing. One can affect the other. But can you talk about that a little bit?
I can say that eating, it fuels the mind and it fuels the body. And I think it relieves certain serotonin, I don't know if I'm saying it correctly, in the mind that helps to regulate mood. And I think healthy eating has a lot to do with your mental health. I think if you're sitting down and just eating pure junk food, just chips, burgers, obviously you gain the weight and it becomes really harder for you to lose it. And you don't go out to exercise as well. So you're gaining all this excess food and you're not exercising, you're just sitting down at home, or you're just taking the car all the time, you don't take time to walk. Nothing's regulating your mind. So you just observing all this unhealthy nutrition, not even nutrition, just unhealthy fats, carbohydrates that, affects the mood a lot. So I would say eating healthily, it makes you feel strong and it makes you feel energized. Along with exercising, it gives you, I think for me personally, when I exercise, when I ride a block and I to go out to the exercise with certain friends, or I notice that that block seems to be uneased a bit, I've got a new idea after that exercise, because that all that energy and you're feeling very energized, so your mind is more clear. I would think with eating, I'm not saying eating all fruits all day and eating unhealthy foods, because I know healthy food can be really expensive as well. But I would say, have a balance. Say, okay, I might have a burger this Friday, but for the rest of the day, try and, well, rest of the week, try and eat something not not with a lot of how do I say it, with a lot of oil or salt, or try to be productive eating, because even though they said, oh, I only have one life to live, so I'm gonna eat what I want, as my mom would say all the time. Try to encourage her to, okay, instead of eating white rice, we'll eat brown rice today, and we'll eat chicken instead of pork, because meat is not really good for you. It causes high cholesterol, can cause heart disease, which affects the mental health itself. Because when you have mental health
Thank
and you have
you.
heart disease, it's oh, okay.
Yeah, thank you. Those were some really good points, and I'll just mention what you were talking about reminds me of the idea of mindful eating. So coming back to kind of my field as far as chronic illness and disease, again, we tend to talk about those two things, the guidelines that you may hear the providers give about diet and exercise. But really, as for Black Beetle Health and other practitioners right now, we're talking about how do we want to feel as a result of making certain changes in our lives. And I think that, and please tell us in the chat. I don't want to speak for anybody. Please tell us in the chat how you feel about this. The idea of how does a certain thing make me feel? When I eat a certain way, does it give me joy? Does it make me feel better? Do I, we joke about in certain settings, we might say, I ate Christmas dinner and I immediately went to sleep. Like, does that make me, how do I feel as a result of eating this particular way? Or how do I feel in certain spaces? Do I feel confident? And of course, as far as having self-esteem, we can have self-esteem regardless of our size. But if there's something that I feel like I want to do to change my outward appearance in order to add to the confidence that I have on the inside, what can I do to change that? So those are some of the questions that we can kind of make that shift to have a more personalized, a more realistic outlook on linking our weight, our physical appearance, our mental health, and how we feel about ourselves. Somebody in the chat, and I missed a comment a couple minutes ago, where somebody mentioned that they're a type 2 diabetic, also recently diagnosed with binge eating disorder, and there's zero information about that. So yes, absolutely. Getting that information, sometimes it can feel like things are just along one track, and there's not information about putting different conditions, the effect of different conditions together. So that's
Can I just add
go
something?
ahead, Adelaide.
Sorry, I know that somebody had asked about information of health at every size, and it is really important to say that it is is a set of principles, and it is an approach that is registered to the Association of Societies of Diversity in Health. So if you do want to know more about that, I would go there. There's some books that have been written as well about health at every size, and there's some other kind of like anti-diet books that also reference that framework. And I think it's really important. I think it was Jax that had said, sorry, I just given your government name here in the live recording. Sorry about that. Just to really importantly is that if you are looking for support around a chronic condition and making choices around food, I would look for somebody, a nutritionist who is trained at a health at every size approach, because what we do find and what we will find consistently is that the advice that is given sometimes by nutritionists and dietitians by our National Health Service, it is basically about restriction. It's not about intuitive eating. It's not about eating the things that you want to eat and the things that feel good for, that feel good and make you feel satisfied. And for a lot of us, we actually don't respond to those signals anymore anyway, because of social conditioning. So when you're saying to somebody, well, just kind of eat what you want to and like stop when you're full, for a lot of people, because of social situations and social conditioning and things like that, they may not have a concept of what that is. And obviously then again, if you're adding in sort of like a chronic health condition, then there might be certain foods that do become restricted, which can, any sort of like restriction will lead to a kind of loss of control around eating. And this is really important to consider, because we've talked about sort of social economic status, but also, if you have grown up in any kind of food poverty, if you've grown up with any kind of uncertainty about where your food is going to come from, whether you can eat the stuff that you like or whether you just have to eat what's put on the table, all of these things are going to impact the way that you as an adult interact with food. Okay, and it's really important to recognize that. And I think that it's something like only 30% of the kind of our body makeup, how we present in our body shape and size, is actually to do with the nutrition, and the rest of it is to do with the politics and the socioeconomic status and the access to certain things, and the kind of the skin color and those, and our genetics and all of those kind of things will affect you. And I think one of the kind of biggest fallacies is this idea that health, that it's an individual issue, that it's not when we talk about fat phobia, and we kind of touched on it before, that it's not an individual discrimination, it's a systemic discrimination. And the reason that you might feel bad about yourself because your body looks a certain way is because of the ideals that are kind of paraded and perpetuated. The reason that you might be in a bigger body and lose weight and feel good about yourself and feel happier, and you feel like your mental health is happier, is because all of a sudden the world around you starts to recognize you. They see you, and people are saying, oh wow, don't you look amazing? Everyone wants to make a comment on your body where they didn't even see you before and they weren't kind of recognizing you. And we have to be really mindful. We do this with celebrities all the time. We have no idea why that person lost weight. We don't know what's going on in their personal life. They could be grieving, and that's why their body is as they is. They could be restricting and indulging in disordered eating, and that is why their body is how it is. So we have to be sort of, I would really encourage anybody here who is in the habit of making comments about other people's bodies, even if you think you're being really kind and polite, please don't do that. It can be very activating for certain people that have struggled with their bodies and their mental health around that. But also, it's kind of none of your business. And just to sort of hop on something else, sorry, I've got a whole load of things. I've just been like holding on to them, saving them. Body autonomy. You do not owe anybody anything about your body. Okay, you don't owe anybody health. You don't owe anybody a particular size. You don't owe anybody a particular weight. What you do with your body is what you do with your body. And if, the research is saying there is an increased risk, and they give you the actual number of what the increased risk, rather than just saying it's doubled, and then you're like, oh, it's 1 in 500,000 and now it's 2 in 500,000. It's like, well, how big is the risk actually? But the thing is, it is for you to decide what decisions that you want to make. Is it that when you for me personally, when I was at university the second time, I decided to take up trampolining. Why? My knees didn't thank me for it. I had periods of time because our bodies fluctuate in size, in weight, etc. I had periods of time where that felt uncomfortable for me, and for me to perform really well doing what I wanted to do, I had to think about, okay, well, are there some changes that I can make? But I have to be really mindful about, why am I making those changes? You know, there was something that I kind of wanted to say around the fact that fat phobia and body weight stigma doesn't benefit anybody, even people in smaller bodies. Though that kind of discrimination is more individual as opposed to systemic, but it doesn't support anyone. So we really need to just kind of think broadly about, you know, what is it that we really mean when we say to somebody, well, I'm just worried about your health. Okay, unless you're their parent and they're a child, they're not an adult, is it your place to be worried about that person's health? Ask yourself that question. And if when you say you're worried about their health, you're worried about their insides and not their outsides, how can you support them if they want to make a change in certain behaviors to get to where they want to be? Don't give unsolicited advice. Just to kind of track back quickly, sorry, because I've been talking for a little while, but just to track back quickly to my area of sort of work and related to maternity care, I read on the RCOG, it's the Royal College of Obstetricians and Gynecologists, that people with a BMI of over 30 should be screened for mental health conditions, because they're at an increase of poor mental health in pregnancy. And I thought, well, I wonder why, because the minute you step in, you book that pregnancy, everything is about the BMI. Everything is tied into, well, you could do this, but you can't, maybe you can't do that, or we'll allow you to do this and we won't allow you to do that. And there's already enough of that gatekeeping anyway that happens in maternity. So there's a part of me, when we're talking about, is it the body that is responsible for the mental health, or is actually the mental health a result of the discrimination that occurs because of the body that you're in? And I think we need to think holistically when we talk about health. It is not just one thing, and you can't tell the health of somebody just by looking from them on the outside.
Right.
Yeah, and it's definitely important.
Yeah.
Yeah, it's definitely important to think about what you're seeing, and really be in touch with how you're feeling, be in touch with how things are functioning. There's a lot of the literature I came across as well that, is saying if you see hypertension, you will see erectile dysfunction. If you see high blood pressure or diabetes, you will see, dry, dry vagina, dry vaginal representation or presentation. It's very black and white, and it feels very sensitive in that within sexual health. But it's really about, how are you feeling? What are you seeing? What are you hoping to achieve? What are you hoping to be able to share with a partner or a number of partners? And if you are seeing that in the literature, and it's saying that you should be, if you have these things, you will be seeing these things, but you don't see them. That is the first question. You don't have to be an academic, you don't have to be a practitioner, you don't have to be a clinician to say, I'm reading here that it's saying as long as I have these things, I should be experiencing these other, these symptoms or these outcomes. I think it's really important just to think about what you're hoping to achieve. And there's someone I've connected with recently, Sue Sutherland, who does a lot around sort of gender, and I think she's actually joined the event today as well, sort of gender, sex and relationship diversity and the trauma that can be around that as well. And some of that's generational, that we have picked up from things that our parents have said to us, or that our family members have said to us, and how to go through a process. And she publishes they published an essay, excuse me, Sue, that speaks about how exploring sort of sex education, sexology, body work, and working through accepting yourself exactly as you come, and going through a process with a coach who, helps you to just go through a process of exploration and maybe even consider things you never thought about. They refer to in their thing, excuse me again, Sue, that something as simple as propping a mirror up and going, I have never seen myself from that angle. How do I feel about that? And it takes you back, and you go, that is so true. Have I taken time to explore myself from different angles as I come? body weight from quarantine was mentioned earlier on, as I come, not thinking that anybody else is not affected by that, as I come, as you come, representing, a process and a journey is what's represented in this particular essay of self-discovery and things like self-touch and things like accepting it, taking time to look in the mirror and just saying, here I come, this is as I am, and not comparing that to anything else, and how liberating and how empowering that can be. And that's really where I stand with that. So.
Thank you so much. That was an excellent summary of what we've talked about, the take-home point that we really want to leave you all with today. Thank you for the great discussion in the comment section. I want to keep this going, but in the interest of time, I'm going to go back to one word, one phrase that was used by a couple of our panelists, and that was body autonomy. Autonomy meaning you are in control of yourself. On the other hand, it also means that while we acknowledge that there are systemic issues affecting your ability to access resources, to achieve certain health goals, or while there may be systemic issues affecting how you are considered to, how you are considered to be, whether or not you're considered to be quote unquote healthy. There are systemic and historical impacts surrounding that. However, ultimately, we want to leave you with the idea of body autonomy, meaning how you feel about yourself, how you interact with the world, what you want to be able to achieve, and whether weight is a part of that, then pursue that. Whether it's seeking mental health services as a part of that, pursue that. Whatever that thing is to allow you to feel to feel in charge of your destiny, pursue that, because we want people to have a well-rounded quality of life, and that's that's the best that we can ask for. Couple things as we close. I want to make sure that you all follow us on social media. This is going to be up on YouTube, so you'll have the opportunity. There was so much that we discussed and didn't have time to even go into. Please watch this again on YouTube, share it with somebody that you know who might benefit from this. You can also follow us on our Instagram page of Black Beauty Health, also on Facebook and Twitter. Keep in touch with us and see what other campaigns we have. We always have a new campaign every month going forward, so please stay in touch with us for that. We also have our website where we signpost a lot of resources from different areas that we've touched on, and we're always seeking to add an update to that. We currently have our health guides for the sexual health and mental health areas. The chronic illness and disease health guide is coming soon, so look out for that. Also, as somebody mentioned a little while ago, quarantine is affecting all of us. So we have a little something for those of you who might need a little care package. So you can check out information about that. If you sign up for our newsletter, you can find out how to get a care package from us as well. I want to thank our panelists for being here this evening. Adelaide, Harvey, Philippa, thank you all for your expertise and your personal stories as well, because of course, this is not just what we see on paper, but it touches all of us and our families and our communities as well. I want to thank everyone who has attended today and who has been vulnerable in sharing your experiences with us. And we hope to see you all for our upcoming events. So thank you all so much and have a good evening.